superficial inguinal nodes, superficial region of the thigh is what it drains. We've got the deep inguinal nodes, which drain the deep portions of the thigh. These are also located within that femoral triangle here, the deep inguinal nodes, and we'll talk more about them later. And then finally, we have the popliteal nodes, which are in that popliteal fossa, just right behind the knee, deep there. And those drain the structures of the lower part of the limb to the leg. And this is predominantly the superficial structures of the leg. So we can get like sarcomas and melanomas in muscle tissue. So sarcomas, muscle, tumors in the muscle, melanomas, tumors in the skin. But in addition to potential cancer spread, a big reason to look at lymph node enlargement is also spread of infection. So injuries to the lower limb, those lymph nodes, you'll be able to determine which lymph nodes might be enlarged based on the location of the injury. So superficial injuries to the leg, you're going to be looking for potential enlargement of the popliteal nodes, etc. Okay.
Is it cancer?
So yeah, you can have
infection.
Yeah, so infection from injuries. Yeah. It's warm in here again today. All right. All right, so then we keep talking about deep fascia of the thigh, and now let's identify those. We have two regions. We have the region above the knee is called the fascia lata. It reaches from the inguinal ligament to just above the knee. And this separates deep structures versus superficial structures. So the superficial veins run on top or superficial to that deep fascial layer. It's just below the subcutaneous fat layer too. Okay, it is continuous with the deep fascia of the leg, which is just that fascial layer below the knee.
I'm sorry, could you repeat what it separates?
Sorry?
Can you repeat what it separates?
So it separates the subcutaneous fat and skin, all of that, those superficial layers of tissue from the deep layers of tissue, which should be the muscles and the deep vessels. So our superficial veins that we just talked about will run superficial to this layer of fascia. Okay. Now if we take a look at the side of the fascia, you can look at the extent of it. So it comes all the way up to the iliac crest and kind of tapers down here around the edge of the gluteal region here. Actually provides an attachment point for some parts of the gluteus maximus. And then we have this thickened band right through here. This is a thickened area of the fascia lata. And this is the iliotibial band. I think I have that on the next slide, don't I? Yeah, iliotibial tract. So either one of those is commonly used. So the iliotibial tract has an attachment up here on the crest of the ilium. Also is connected to the tendons of the tensor fasciae latae muscle and also the gluteus maximus. So those three structures are where the iliotibial tract attaches superiorly, travels down the lateral portion of the thigh, and then attaches to the tibia here, the lateral condyle of the tibia. Based on its function, or based on its structure, what would you guess its function to be? Any guesses? It can stabilize a joint. Which joint do you think it'll most actively stabilize?
The hip.
Yeah, so it's going to help stabilize the hip, and it's also going to help stabilize the knee. So it's particularly useful in extension of the knee, helping to stabilize that, keeping lateral motion from being too much, and then helping to stabilize the hip joint some too. So we also have this thing called the IT band syndrome, and so right here, this part of the IT band passes over the lateral femoral condyle, and so the condyle is kind of this bulge out of the lateral part of the femur, and so with every step and every time we bend our knee, that IT band passes over that condyle. Okay. In long distance runners and long distance cyclists, you can imagine how many times that happens during a long run or a long ride. And so when they're in training and going those long distances, that friction between the lateral condyle of the femur and the IT band can cause inflammation in this portion of the IT band. And that would then cause pain at the lateral portion of the knee. Also can have the same thing happening between the IT band and the greater trochanter of the femur, so up in the hip region. So you also can have hip pain from IT band syndrome. If it's bad enough, they can do like an MRI or CT and actually see some edema underneath the IT band, between the IT band and the underlying structures.
What did you say the IT band rubs on?
The lateral condyle of the femur, so that lateral bulge right as it's going into the knee joint. We'll have a slide next class period on that. Or the greater trochanter of the hip.
So the ones who have the lateral condyle femur where it's irritating there, the pain is generally in that area then?
Absolutely.
Versus the ones at the greater trochanter?
Yeah, so you'll either get pain in the lateral part of the knee or in the hip area, depending on where the rubbing is. Good. Any other questions? Okay. All right, so then another feature of the fascia, of the fascia lata, is a aperture right here, the saphenous ring. And this is the hole where the great saphenous vein dives deep through the fascia lata to join the femoral vein. Excuse me. Okay. If we take a look at that compared to the inguinal ring, so the superficial inguinal ring is just medial and just superior to the saphenous opening or the saphenous ring. And this is going to become important when trying to diagnose hernias of the groin. So we can have inguinal hernias. We also can have other types of hernias. One of them is the femoral hernia. And that one is usually palpating the saphenous opening is where we can identify those. We'll talk about that more later, but that's why I'm bringing up this saphenous opening and the inguinal opening, their relation to each other. Okay, so then in lab you've been learning the femoral triangle. So we'll just touch on it here today too. So it's that space here, this triangular space, inferior to the inguinal ligament and bordered by two of the muscles of the anterior compartment of the thigh, predominantly the sartorius muscle, providing the lateral border, and the adductor longus muscle, providing the medial border and part of the floor.
Which muscle?
The sartorius muscle is the lateral border, and the adductor longus muscle provides the medial border and part of the floor. The other part of the floor is the pectineus muscle. So those three muscles kind of make up the major structure of that femoral triangle. Now, beyond what we studied in lab, the femoral triangle extends downward into the adductor canal, which is basically a fascial-lined canal where all of the major deep neurovasculature of the thigh runs. You can see this extension of that green thing down, and it actually extends down to the popliteal fossa. Okay. So what is in the femoral triangle? So you guys tell me, starting laterally, what's the first part of the contents of the femoral triangle? Femoral nerve, right? Then what comes next? Femoral artery. Then the femoral vein. Yeah, and then we have the lymphatics in the femoral canal, and these are the deep inguinal nodes here. So remember, we have our, what's the word I'm looking for? Can't remember what those learning tools are with the abbreviations. Thank you. Good grief. Anyway, so it's navel, right? N-A-V-L, starting laterally and moving medially. Good. Yeah, you guys got that. And again, those structures continue, where'd my thought go? There we go. Continue down through the adductor canal to the popliteal fossa here. Okay. Another thing I want to point out here is the femoral sheath.
Hold on just a second.
Yep. Tell me when you're ready to move on. Okay. Cool. Any questions? Anything I need to go back and cover again?
On the previous slide,
Uh-huh.
the adductor canal goes through the adductor hiatus to attach.
Yeah, so that the adductor hiatus is kind of the end of the
Is
adductor
the end,
canal.
okay.
Yeah, as it's transitioning into the area of the popliteal fossa. Okay, so I just want to point out one more thing on this slide, the femoral sheath. And this is a band of fascia that surrounds some of the contents of the femoral triangle, basically everything but the nerve. So the nerve is lateral to the femoral sheath. So we've got the artery, vein, and lymph nodes within that femoral sheath. And the reason I point that out is this opening here at the top, we actually have quite a bit of space around the lymphatics of the femoral canal where a loop of bowel can protrude, and that's actually the site of femoral hernias, is protrusion of bowel through this opening of the femoral canal.
So the femoral canal is just an opening in the femoral triangle?
It's basically a cone-shaped piece of fascia that actually is an extension of abdominal fascial layers that comes down and surrounds the artery, vein, and lymphatics.
Oh,
and
like the femoral
continues.
triangle is just an area,
Right, it's just that area where all of that vasculature passes from the superior structures, the abdominal and pelvic cavities, into the lower limb. Yeah. Okay. Any other questions?
What did you say was the hernia?
Sorry.
What was the hernia that you said?
Femoral hernia. Mm-hmm. Any other questions? Yeah.
So the femoral hernia comes through the sheath?
It comes through the opening of the femoral canal. So that area that's surrounded by the femoral sheath is what we call the femoral canal. And is that opening into the abdominal cavity is where the hernia bulges. We'll revisit the hernias a couple times more in this lecture. Okay, any other questions?
So the
Yeah.
saphenous ring, you said
Sorry?
Sorry, the saphenous ring.
The saphenous ring is, whoops, wrong button. It's basically right here, and that is through the fascia lata, so that's one layer above this femoral sheath.
Did you say that hernias can also,
If a late stage or a more complicated femoral hernia can actually push through the saphenous ring, but even if it isn't pushing, that's one opening in the fascia lata where we can feel whether the hernia is in the femoral canal. And we'll revisit that later too.
would those be direct hernias?
There's no indirect versus direct hernias when we have the femoral hernia. It's just femoral hernia. Yeah. Only the indirect and direct when we have the inguinal hernias. Yeah. Good questions. Any other questions? Okay. All right. So here's just the surface location, right where you would expect to see the femoral triangle. So you can palpate the anterior superior iliac spine. Well, that got cut off. And the pubic tubercle. And so then the inguinal triangle or inguinal ligament is obviously running between those. And so that's our superior border of the femoral triangle here in this anterior medial portion of the thigh. Also, I want to point out, so right about here, this is where this stylus and pen would be so much more helpful. Oh. I was planning it out last night, now we can't do it. So this area right here, right above the inguinal ligament would be the approximate location of the superficial inguinal ring. And so then here, kind of right here, lateral to and a little bit lower than that superficial inguinal ring would be the saphenous ring, about the same level as the pubic tubercle. So much better if I could have drawn it. So sad.
You're just circling this the location of the what?
The saphenous ring, yeah. So saphenous ring would be in this area-ish, right above that femoral vein, and then the superficial inguinal ring would be approximately here. Okay. We good? All right. So here is our formal start of the discussion of the femoral hernia. So like I said, femoral sheath is that band of fascia surrounding the artery, vein, and nerve, and that is the location where the loop of bowel can protrude down into the femoral canal. They're more common in females than in males. So remember, the inguinal hernia is more common in males than females because of the larger contents of the spermatic cord running through that inguinal canal. Well, here, because females on average have a wider pelvis, the opening of the femoral canal is a little bit larger. So it's a little bit more likely for a loop of bowel to be able to protrude into that femoral canal in females than in males. Okay. So then remember then that we can palpate the saphenous opening and have them do the turn your head and cough thing, and by palpating the saphenous opening, if we feel a structure pushing out against us during that test, we can be more certain that we have a femoral hernia. Mm-hmm. So then what would it look like? Typically it's a protrusion on the upper part of the thigh, lower than where we would see an inguinal hernia in general, but again, you have to verify by palpating the 3 different potential sites for protrusion of the hernia. So here you can see a loop of the bowel protruding down into the femoral canal, and this would be a late stage hernia where it's actually protruding out of the saphenous ring as well.
Just to clarify one more time,
Mhm.
the femoral sheath goes through the saphenous opening then?
Sorry?
The femoral sheath goes through the saphenous opening?
The femoral sheath is deep to the fascia lata, right? So, it could be, well, actually, you know what? That's a good question. I don't think the femoral sheath protrudes. It's the loop of the bowel that protrudes, but don't quote me on
Would
that.
it take the sheath with it? Cause it looks like it's coming down.
Right.
Through the sheath, so they push the sheath and then
Didn't you
just
say that's
out.
the
Cause it looks like a.
Right, that's a
cross-section,
good
it's like
question.
really-
Yeah, I don't know the extent of the sheath down, how far down it reaches. That's a really good question.
Didn't you say the part where the hernia comes out, where the fascia opens up?
So the fascia, the part of the opening that, I was talking about the saphenous opening here. So that's,
I think it's just.
that's the layer, where we can actually feel whether there's a.
Yeah, it has-
Yeah, I don't think they check.
We're not checking for
Femoral.
femorals, we're checking for femorals.
Okay, what,
What works the cover?
Right, yeah, covering it, pop, coming out with it.
yeah, that's, if the femoral sheath extends down that far, then yeah, it would be a bulge in the femoral sheath as well. If there's a tear in the femoral sheath, then the bowel would protrude through that as well.
You were saying earlier it covers the fascia lata, and the fascia lata goes down further too, so.
Right.
Wouldn't, I would assume that it'd go down further, the sheath would go down. So-
We could assume that, but that is an assumption. I didn't read anywhere how far that femoral sheath actually extends. So from this image, it looks like the femoral sheath doesn't extend
Yeah,
very
it's like
far.
this Here, like little.
But you-
Part together at the top.
Exactly, but you never know whether this is really what's happening or not in diagrams. So, the basic idea, at least as much as I can cover in this class, is the loop of bowel protrudes down through the femoral canal, and we can feel it at the saphenous opening, even if it's not protruding through the saphenous opening. We can feel it because that's one part of the deep fascia of the leg where it's not compressing it. So fascia lata is going to compress everything fairly well, and so if it's not a very big hernia, then we'll be able to still feel it through the saphenous ring because that's that opening in the fascial lata. Does that make sense?
So basically to find that area, are you just finding your femoral artery and then kind of feeling in that area? Because I'm trying to figure out how you're gonna feel that.
I have no idea. Not being a clinician, I have no clue. But at some point, somebody will teach you that, I'm sure. So, just for this class, kind of being aware of the general location, somebody will help you with the palpation of that at some point. Yeah. Okay. Does this make sense? Any other questions? Anything we need to clear up on it?
Treat this type of hernia.
You have to surgically go in and
Surgically go in.
fix it. You have to pull the loop of bowel out where it's not supposed to be, and then they usually put a layer of mesh to prevent it from protruding
So do
through
you
that
go in
again.
from that way, or do you go in from the actual?
I don't know.
Curious.
Yeah, I have no idea. All these things that would be so nice to know.
I know, right?
Sorry? Absolutely. So if it twists or it becomes impinged somehow, then you can have strangulation of the hernia, which would then cause that to become ischemic, and then you've really got some issues. Yeah.
Is it painful?
Yeah, so anytime you have movement of the bowel maybe further into the region, it becomes, has at least a discomfort. It just is kind of this weird feeling, at least for my hernia, it just felt weird when it was
So
moving.
pain in the abdomen or more in like the femoral?
So it's in the region where the hernia actually is, because you're getting
Okay.
pinching of that tissue there. But then there's also this just weird discomfort feeling when it's actually moving. It feels weird. I don't know how else to describe it. It just felt weird. Yeah. Okay, any other questions? Okay, so then we can look at some MRIs of it. So this is the same patient, 3 different views. You can see here the protrusion here in a sagittal view. So here's the loop of bowel protruding out into the upper part of the thigh. You also see it here coming up over the lip of the pelvis, and then also here protruding out. Okay, so just some experience looking at these MRI images. Just so you guys know, radiopedia.org is an amazing website if you want to learn anything about diagnosis of some sort of injury or a hernia or something like that. It has descriptions. It has CT scans where you can scroll through the whole layers. Has MRIs where you can scroll through all the layers. It's amazing, so much fun. So I recommend Radiopedia. It's pretty awesome, and they're all put together by clinicians. So yeah, pretty amazing. Okay. All right, so that's femoral hernias. As much as I can tell you about them, anyways. So then let's move to the gluteal region. And we're going to start with the major muscles of the gluteal region. So one of the major ones is the gluteus maximus, obviously. I have in my notes, which are posted, the extent with which I want you to know the origins and insertions. So I'm not having you learn exact locations. I want you to know the major structures, okay? So for the gluteus maximus, it's attached to the posterior part of the ilium, behind the posterior gluteal line, and then structures, both the bone and the fascia and tendons along the edges of the sacrum and coccyx. Okay, that is as much detail as I want. We could go into lots more detail in the book. You have the exact origin sites, but I just want you to know the basic structures. Okay. The other end of the gluteus maximus is attached to the iliotibial tract and to the gluteal tuberosity. So those two structures for the insertion site. Okay. And then what would be the innervation of this muscle? Does anybody know innervation? Inferior gluteal nerve. All right, and so if I was to say a patient had damage to the inferior gluteal nerve, you should be able to say weakness of the gluteus maximus, which would cause a deficiency in, what do you think? Hip extension, especially from a flex position. So gluteus is the most powerful hip extensor when we're moving from a flexed hip to an extended hip. So basically standing up, things like that, okay? So powerful hip extensor. All right. The others, I would like you to, oh no, this is still gluteus maximus. So again, remembering it attaches to the iliotibial band through this portion of the, what's the word I'm looking for? Whatever. It attaches to that portion of the iliotibial band. Can't remember what I was going to say. Whatever. All right. Other muscles of the gluteal region I want you to know. And I'm going to group these in their functional groups. So we're going to start with the hip adductors. And hip adductors are which ones?
You say ad or ab?
Abductors, sorry. Abductors. Abductors, hip abductors, taking away.
Abductor.
Yep, abductors. So that would be the gluteus medius and gluteus minimus.
Okay, so these are, okay.
Did I say it wrong in the notes?
Yes, yeah, here it says adductors.
Oh, obviously I was tired.
Yep, maybe,
Okay, abductors, taking it away. Goodness, wow.
You said gluteus medius and minimus?
Mm-hmm. Those are both adductors, abductors. I'll get that straight one day. If you guys don't get completely confused by the end of this lecture, I'll be shocked. Because obviously I can't keep things straight today. Okay, so abductors, okay? Gluteus medius, the origin is between the posterior gluteal line and the anterior gluteal line. gluteus minimus between the anterior gluteal line and the inferior gluteal line, right there. And they both attach to the, excuse me, greater trochanter of the femur.
Can you repeat that?
Mm-hmm. So origins are for the gluteus medius between the posterior and anterior gluteal lines, and the gluteus minimus between the anterior and inferior gluteal lines.
Thank you.
Mm-hmm. Okay, so those are the abductors, and they are innervated by what nerve? Anybody know? Superior gluteal nerve, yep, good. And so then if there's damage in the superior gluteal nerve, we'll have weakness in these muscles. And we've got a slide coming up, I think. I think I put it in there. Did I? Oh yeah, in a little bit, we'll talk about it more. Okay. We also have the hip rotators, okay, and as a group, these are going to laterally rotate the thigh. Or, and that's when the hip joint is extended. If the hip joint is flexed, then they are considered to abduct the femur away. So when the hip joint is flexed, they'll abduct the thigh. We've got a few of them that we need to know. We need to know the piriformis, which we've been learning already. Obturator internus, the gemellus superior, gemellus inferior, and quadratus femoris. Each of these has its own site of origin at some point on the pelvis or in the anterior aspect of the sacrum, and then they all attach to the the femur. Excuse me. Most of them to the greater trochanter of the femur, or for the quadratus femoris here to the intertrochanteric crest. So a bulge of the bone along that intertrochanteric line between the greater and lesser trochanters. Okay. A whole slew of nerves innervates them. Some of them are innervated by nerves that are specifically for that muscle. So like the nerve to the obturator internus, obviously is going to innervate the obturator internus, etc. So those, again, are in the notes. I don't feel the need to go over them in detail. But no, like I've been doing with some of the other muscles, if you have some sort of impingement or paralysis of that nerve, what's the muscle that's going to be weak? So, like for obturator internus, it's going to be parts of the obturator nerve, etc. Okay. That's pretty much all I wanted to say about that one. Oh yes, so then there was one more muscle I wanted to know for lateral rotation of the thigh is the obturator externus. So the previous diagram didn't show it well, but you can see it poking out here, attached to, again, part of the greater trochanter of the femur, and its origin is kind of the other side of the obturator foramen as the obturator internus. So just kind of think of them as the two sides of the muscle that covers over the obturator foramen. Okay.
That also does lateral.
Lateral hip rotation. Okay, so then back to our hip abductors. Wow, I really was tired last night. So remember we had a slide similar to this at the beginning where we have some pelvic tilt during the swing phase of of locomotion, but we have contraction of our abductor muscles, the gluteus medius and gluteus minimus, to prevent over tilting of, so excessive tilting of the pelvis. So part of the stance portion is contraction of these muscles to prevent that pelvic tilt. Now, if we have damage to that superior gluteal nerve, we can get excessive tilt of the pelvis here. And this produces a particular gait that is indicative of this kind of damage. It's called the Trendelenburg gait. And where you get excessive drop of one hip, and a lot of times this is just on one side. So a patient would walk in a way where when they take a step with one side, they get excessive drop of that pelvis on that side, and then maybe have a fairly normal step, and then excessive drop of the pelvis. So you're seeing that excessive pelvic tilt when they take step, when they're standing on the side that has superior gluteal nerve damage, or some sort of other paralysis of the gluteus minimus and gluteus medius. Okay? All right. Innervation of the gluteal region. So we're getting very familiar with superior gluteal nerve and inferior gluteal nerve. Those are really the only ones that I want you to know by name. The others are all just nerves to a particular muscle, nerve to quadratus femoris and obturator internus. The other one I want to point out is the sciatic nerve. So it does not innervate anything in the gluteal region. It merely passes through. But we have to keep it in mind because it's one of the major nerves of the body, and being aware of its location is important, especially during gluteal injections, right? So we can divide the gluteal region into quadrants. So the vertical line goes from the highest point on the iliac crest down through the lesser trochanter of the femur, which is also about the same level as the ischial tuberosity here. And then a horizontal line dividing the quadrants. It's about halfway between these 2 points here. And so the sciatic nerve is typically found in the lower medial quadrant. So then to get away from it, a good safe injecting site would be the upper lateral quadrant there. Got lots of those gluteal muscles available, as well as being away from the sciatic nerve location. Here you can see it's, again, in different locations, surface anatomy here. My question would be then, why not potentially have an injection site in the upper medial quadrant? Why would that be a bad idea?
There's not a lot of muscle.
Okay, this is possible. Remember, we have different locations for the sciatic nerve. It can go, yep, it can go over, through, or under the piriformis muscle. So if it goes over the piriformis muscles, it can loop up into that upper medial quadrant. So making it a non-ideal site for gluteal injection. And then we'll just finish up quickly with the vasculature. Very simple. Most of its branches of the superior gluteal artery and the inferior gluteal artery. Rest of it's just small branches. So 2 that we know well, just get to know them better. All right, is that the last slide?
Yeah.
Oh, cool, okay, so we're done.
Watch the internet work now.
I know, right? Oh.